Someone would have normal glucose regulation in normoglycemic, even when they're type 1, type 2, or other specific types, or even gestational. But then that kind of deteriorates. There's an impaired glucose tolerance or a prediabetes where the fasting glucose goes off, and that would proceed. For type 1, insulin is required for survival. Like I said, for type 2 and other types, insulin may not be absolutely necessary. Some people might need it, yes, but not everyone. So let's talk about type 2. Like I said, it accounts for around 90% of all the diabetes patients worldwide. It's progressive. So it happens and gradually gets worse over a long period of time. So our job would be to catch it at the beginning and prevent it from getting too bad. So many people who have type 2 diabetes don't know about it, because the symptoms that we know, polyuria, polydipsia, losing of weight, these things don't always happen. And right at the beginning, definitely they won't happen. So they'll be roaming around with high blood sugar and a milieu of hyperglycemia in their body, and they're all undiagnosed. And that's why the complications are so much higher. So we need to screen, we need to catch them early. Like I just said, because we don't know about it, the complications are higher. So thinking about the pathophysiology, we need to know a little about how it's happening so that we know how the medicines work. So initially we had thought about 3 or 4 reasons only. There's a genetic predisposition. There are some environmental factors. Because of this, obesity prevails. Because of the genetic predisposition, there is insulin resistance, and the pancreas doesn't function very well. So there's reduced insulin release from there. There's a lot of extra glucose coming from the liver, and the muscle is not using up the glucose as it is supposed to. That leads to elevated sugars, and elevated sugars after crossing a certain level become full-fledged type 2 diabetes. So from the triumvirate, we now realize that there's an Ominous Octet. So 8 reasons in an 8 format. There's less insulin secretion, there's more glucagon secretion. So whatever insulin does from the beta cells, alpha cells have glucagon and does the exact opposite. Then there is increased production of glucose from the liver. So the storage cells are broken down. The brain has some neurotransmitter dysfunction. So we're not using up sugar properly. The muscles are not using the sugar properly. The kidneys don't absorb it well, or absorb it a bit too much. And it's released in, not released in the urine as it's meant to be. Fat cells are broken down to release sugar. And then there's incretin. So with these 8 different methods of hyperglycemia, we have actually found 8 or more different developments in pharmacotherapy. So every place that we've realized that there's a problem that leads to hyperglycemia, in all those different places, as you can see, different medicines work. So that's how we actually decide which particular medicine will work best for our patient, if we can have a little idea of what led to the hyperglycemia in the first place. It's not easy, but sometimes given the patient's history or the way the patient is, the way the patient reacts to food, we can decide on what would work best for them. But it's mostly a trial and error. So we need to follow up our patients very frequently at the onset of treatment. So how do we diagnose diabetes? This is an ADA guideline that is given, and it's followed all over the world. Your fasting sugar more or equal to 126. That is the cutoff. This cutoff has been decided because at 126, we start to see micro and macrovascular changes because of hyperglycemia. So once you see someone with 126 fasting blood sugar, there's no choice, there's no thinking, there's no waiting. Start medicine, start treatment. If we have a random sugar or a PP sugar above 200, that one also tells us that yes, the patient has diabetes. Or if the HbA1c is more than equal to 6.5. So as you can see, it's not and, it is or. So if a patient comes to us with any of the following things, we can legally and we should start treatment. There is no waiting, there is no trial period. So let us see, let us start exercise, let us try and test again after a week or something. There's nothing to wait for. So whenever you find a patient with a fasting sugar of 126 or above, with a PP or a random sugar of 200 or above, or an HbA1c of 6.5 or above, let's counsel the patient and start off some medication, because that is where you will be able to get the most benefit out of it. No point in just telling them, okay, come back, repeat the test. That leads to a lot of treatment inertia, and that's why the complications are higher. That's why by the time the patient actually comes to you deciding to start treatment, their sugars might be in the tune of 300 or more. So what's prediabetes? Prediabetes is when the sugars are higher than normal, but not high enough to be categorized into those categories of type 2 diabetes. So again, very clear textbook definition of this: fasting sugar between 100 to 125, a PP sugar of 140 to 200, or an A1C between 5.7 to 6.4. So again, whenever you find any one of these in your reports, please tell the patient, yes, you're a pre-diabetic. Yes, you need to be careful from now. We won't start medicines right away, but we are going to insist that the lifestyle be improved and start giving lifestyle advice. Tell them what kind of diet they should take. If you have a good dietitian's network, immediately give a reference to a dietitian. Tell them what kind of exercise would be efficient, would help in keeping their sugars under control. And I'll give you little guidelines for what you can tell your patients. So the risk factors for pre-diabetes are actually the same as diabetes: one who is overweight or obese, someone who has a sedentary lifestyle, that means almost all of urban people these days, a family history of type 2 diabetes, having gestational diabetes, ethnic background, people from Asian countries, Indians. So if you're in the US, in the UK working, and you find someone with an ethnic background, they are more prone to having diabetes than the Caucasians. And then high blood pressure, because the whole idea of insulin resistance kind of runs along with these things. So when do you screen? You start screening when you find an overweight or obese adult who has one or more of these risk factors: a relative with diabetes, high risk race, like I just said, a history of a heart disease or heart disease in the family, high blood pressure, something that we call diabetic dyslipidemia, with a low good cholesterol, low HDL level, and a high triglyceride level. So if you look at a lipid profile, take special note of HDL and triglycerides. The total cholesterol really doesn't tell us much. We need to look at the good cholesterol, the bad cholesterol, and the triglycerides. Someone who has PCOS. So polycystic ovaries also, their pathology is based on insulin resistance. So the same insulin resistance that makes a woman polycystic also would make them prone to diabetes. Someone who is physically inactive, and people who have other rare causes or other conditions with insulin resistance, like a severe obesity or pre-existing acanthosis nigricans, where you see black patches around the neck of the patient, or sometimes different parts of the body, you'll see slightly darker and rough skin. That's when you might want to check their blood sugars and keep them under strict follow-up. So patients who have already been diagnosed with pre-diabetes, you need to check them yearly at least, so that it doesn't get worse. Women who had gestational diabetes should keep on checking lifelong. 3 years, every 3 years, if everything is normal. If they are already in the pre-diabetic zone, then yearly again. For other patients, maybe as soon as they hit 35, at least once, and then check again according to the value that you get. And if the results are normal, there should be frequent intervals of checking. So many patients will say, I've never been a diabetic, and then you find out the last time they checked was probably 5 years ago, and you don't know what happened in those last 5 years. So yes, frequent screening is important. And definitely patients with HIV, because of their treatment, they will be more prone to developing diabetes. And once an HIV patient develops diabetes, they will be more prone to developing infections, which can be fatal because there's immunocompromised state over here. So what are the ADA, American Diabetes Association recommendations for pre-diabetics? One needs to monitor the development of type 2 in those with pre-diabetics, like we already discussed, based on their individual risk and what benefit you'd get out of testing them annually. People who are overweight and obese need intensive lifestyle changes. You need to insist they should try to lose at least 7% of the initial body weight. Once they've reached that target, give them a new target and increase their exercise to moderate intensity physical activity. For example, something like brisk walking at least 150 minutes per week. So it's a good idea to tell people to walk at least 20 to 30 minutes every single day, 5 to 7 days a week, and try to push the importance of doing it every day, not only on weekends. So eating patterns also need to be modified. You need to discuss the patient preferences and what needs to be done, what one needs to avoid as much as possible, and what can be taken to a certain extent. And international guidelines actually tell us that we can start metformin even if you're a pre-diabetic. If the weight is high, metformin can help in weight loss. Metformin is also given to PCOS patients, and it can prevent the progression from prediabetes to diabetes. So yes, metformin is always the first gold standard drug of choice for diabetes, but can also be given as prevention of diabetes. So starting it, there is no fear of starting metformin too early, unless specifically someone has an allergy to metformin, which is extremely rare. And prediabetes is also associated with a heightened cardiovascular risk. So just because someone has not become a full-fledged diabetic yet does not mean the risk is not there. So the screening is required for all the other modifiable risk factors for cardiovascular disease. You need to get a baseline ECG, a 2D echo wherever required. You need to get the cholesterol checked, make sure that the LDLs are at target, the triglycerides are at target, the HbA1c is good and high. Sorry, the HDL is good and high. So comprehensive evaluation. So it should be done at the initial visit to confirm the diagnosis and classify into which group it is. Usually you don't need to go very deep into finding out which kind it is. Most of the time it will be a type 2. Evaluate for complications and potential comorbidities. Review what treatment was already being taken. So many a time you'll find a patient who has probably known they have diabetes, they're on some sort of treatment, but they're not very compliant with it, or it's not working very well for them, or it's only medications and low lifestyle. So you need to literally sit and find out what they were doing till date for their diabetes and the risk control. You need to be starting an engagement process where there's a care management that both of you can follow. You as a doctor needs to give the management the steps, but you need to find out if your patient can comply with that. So ask them, let them be vocal about it. If you give them an exercise schedule that they feel is illogical, let them voice their problem, and so that we can find an alternative for them too. So develop a plan for continuous care. Tell them that this is a progressive disease. It's not like I give you a medicine now. There's a certain course. Patients are very fond of, humne pura course le liya. But there is no full course of diabetes treatment. The course is, as long as you want to stay well and healthy, we're going to have to keep in touch with each other. We're going to have to keep on treating this. We might be able to treat it with the minimum possible medicines, but that's going to be a mutual give and take plan. So this plan needs to be developed. This plan needs to be explained to the patient. So every follow-up visit should have most of these components of a comprehensive evaluation, and the ongoing management should be guided by the patient's current health status, the complications, the heart risk, the risk of having a hypoglycemia. So depending on what kind of medications you're giving them, or the patient's health status, is the patient going to become a hypoglycemic or not? You need to be aware of that and also keep the patient aware of that. And there should be a shared decision making to set goals. So it's not like you write points down and the patient just listens blankly and absorbs nothing and goes home. You need to understand where the patient is coming from and make a shared decision making plan.